Thanks, Megan. Thanks, everyone. So I'm Ari Friedman. I'm a PGY2 finishing PGY2 at Beth Israel and a health economist. I'm going to talk to you today about how we can better understand the costs of military emergency department care, pitching this as a Department of Defense grant. So the background here is that there's lots of concern, particularly in the past year, about emergency department costs in the crosshair. I see everybody loves the random emergency doctor that I picked out of Google Images while I was making these slides. But so it's a topic that's been in the news to a considerable degree, most notably recently, where Anthem is starting to deny care for, or deny repayment for visits that they deem to be inappropriate emergency department visits, arguing that emergency department visits are simply too expensive and that these are inappropriate resource use. But it turns out that what they're talking about and what everybody else in the press is talking about when they talk about emergency department costs is not the cost of emergency department care. What they're talking about is the price of emergency department care. So you can think of the price of emergency department care as the dollars that change hands. It's the payments from the insurers and the patients to the emergency department. There are definitely some reasons to care about that, but that is not the cost of emergency department care, which you can think of, and I want you to kind of fix in your head, as the resources used when an additional patient visits the emergency department. That idea, the resources used when patients visit the emergency department, is the key sort of policy number for determining the efficiency of emergency department care and for trying to figure out what interventions we should do to try to structure our entire health system as the emergency department becomes increasingly the sort of key place where people interact with the health system. So to figure out various things about the costs of emergency department care, we need data and we need some methods. So I have I have data from the Department of Defense, which maintains an incredibly rich set of data that they collect on every aspect of every piece of resource used in their emergency departments and basically all of their hospitals. So this includes, for every patient visit to an emergency department, they keep track of which providers and which personnel, including MDs all the way down to techs, interacted with that patient. They keep track of every disposable supply, including like which IVs were used on which patients. And they keep track of imaging use. The key sort of methodological consideration here is how we allocate the time of those personnel. So if we're just interested in the cost of the average cost of all emergency department visits, that's simple. We take the total amount of time worked and we divide that by the number of patients seen and we get a number. But for a variety of reasons, it's interesting to start studying different subpopulations, so less sick patients versus critically ill patients, uncomplicated sort of ankle sprain type patients. And to do that, then we need an approach. And so my strategy there is to use a regression design to essentially compare how many patients are seen on days with lots of uncomplicated patients to how many patients are seen on days with lots of critical care patients, and to use that to apportion out the personnel time spent. So why do we care? Well, costs matter to the military because they determine how resources are allocated and where potential areas of inefficiency and waste can be targeted within the military health system. Costs matter, but the impact of this extends sort of beyond the military setting to the civilian sector as well, to the health system, because they help us determine, for instance, this key sort of policy question of is there cross-subsidization that occurs in emergency departments? So it's been hypothesized that the several $100s that gets billed when you visit an emergency department for an ankle sprain is not the actual resource use of that visit, and that those extra funds are being used to sustain the fixed costs of the emergency department and the critical care costs, which may be sort of underbilled, and that has various implications for the policy system. So how are we going to accomplish this? So, I've published extensively in the area of emergency department economics and costs, and then my collaborator is Steve Schwab, with whom I have a wonderful working relationship. Our kids have played together. We did our PhDs together, and he's now active duty military faculty and as well as an assistant professor at Baylor. He has 15 years of experience working within research within the Department of Defense and has worked with this data set extensively before. Thanks.
I'll talk about the military piece a little bit, and then I think these other guys talk more about the data. So the what is the data? Is it M2 data, TMDS data, CHS data? What is the DoD data?
Yeah, so so Steve knows the data much better, and this is like deliberately sort of pushing myself into new areas, pitching this. I don't know those terms. So he, again, like has worked with us extensively. We've had sort of a few conversations about what the resources exist, how good the data is. I pushed him pretty hard about they're really tracking IVs down to patients. And if I can sort of infer from your question, there's some skepticism about really how well those are doing that in the context of a daily clinical operation, where it would be very easy to sort of say, oh yeah, that patient used a few. The sort of key policy parameter for this is really the sort of average variable cost of these visits, not the individual patient visits. And so as long as, on average, the allocation of those resources is not biased, then that should be okay.
Good. So I looked up all the presenters today. Obviously, all of you guys are fantastic, and obviously you've done well-educated, a lot of great work, high-impact publications. The DoD data is tricky. So there's M2 data, which is military treatment facilities, MTF, and then there's TRICARE data, which is quite different. And some people say, quote-unquote, DoD data is TRICARE data. That's very different. That is actually provided a lot in outpatient civilian settings, not in the military settings.
Right.
So I think there's been a lot of folks who have gotten in this data and then sort of had some conclusions from it that are inaccurate.
Yeah.
The piece about that they track every IV, 14 years active duty, many facilities I've worked in,
and they don't.
That's not even close. I'm surprised that people say that it's that accurate. I mean, I'd say that military facilities is probably, they track it far less than a civilian hospital. Right, because you don't have to be as accountable to some of the actual individual costs, because it's kind of a socialized network in many ways, at least the military health facilities is. So I have some questions or concerns. We need to dig in a little bit deeper. Your colleague obviously has a lot of experience with data set, but I'd be very careful about extrapolating what's actually happening. I mean, make great headlines, but if it's actually what is in that data, it may not be actually what's being performed.
Right.
And so there's some questions about that. Yep. And then, I'll let you guys go from there.
It's Don. Interesting work. Your hair's getting a little long to work for the military, so get busy on that if you can. My first job out of training was I worked at an active duty military site. And it still sticks with me how starkly different the staffing, resource, and other deployment is, and for different reasons I get to the same point as Vic, is wondering that this may give you a wonderful description inside that microcosm, particularly if it's the active duty facilities versus all the rest. As you get into all the rest, you'll get all the noise that the rest of us live with. It becomes more real world-like, but much more difficult to deal with. That's my biggest concern here, is that you're describing a system that from a real distance looks very much like every other civilian one, but in fact, I think once you're in there, it's really way different. The composition of a care team in an emergency department in an active duty place is dramatically different than anywhere else. When I worked in the military, you could order someone to go home. That doesn't happen in my world.
It's called a security guard.
Yeah, and it's called an televiolent. I mean, these are just really stark, basic things that you're going to draw inferences about, and I would be careful about that.
Okay, sorry. Yeah, he's got some good points. So I forgot. So Don mentioned a specific point that the EDOD facilities, if you're using true MTF data, vary quite a bit. Some of them are super urgent cares that are called emergency departments, and some are level 1 trauma centers. So you can't use all of that data to say this is just like BI or something. Sure. And secondly, the practice behavior globally is probably a little bit similar, but economically it's different. But if you want to look at one specific issue, PTSD, abscesses, that's a great data set. I think it's a bit trickier. I'm not an economic guy, but look at all of the data and compare it to a civilian setting. I think that would be harder to do. I think it's kind of what Don's saying.
Yeah, I mean, so I didn't really get into it, but I think in my mind, like the reason that first kind of this sparked my interest like 5 years ago when Steve and I were sitting in an office together, and he was like, "Really, they have all this data," is sort of basically comparing the ratio of the cost of an uncomplicated visit to a critically ill patient, to the resource use, to the price, right? That an intubation pays the physician like $100, and an ankle sprain pays like $100. And so the question for you then is, do you think that that ratio, like the balance of assuming that we could find some specific disease process, like an ankle sprain or something that's sort of relatively common, pretty well defined, pretty easy to identify, from the overall set of the data sort of starting out, to, a critically ill patient, do you think that ratio would be kind of the same across settings?
Yeah, I don't so much want to answer that. I suspect it would not be, but
Sure.
So first, I want to encourage you. I'd love to see people with strong training in economics go into emergency medicine and pursue careers in health services and health policy research. So you are a breed of creature that we want to nurture and cherish. That
Well, I'm
said,
finishing second year of residency, so I'm kind of stuck at this point.
yeah. That said, though, I think your whole conceptual approach, I think, is really troubling me. Your idea that, well, we're going to look at days where it's mostly not so complex patients versus days where there's a lot of complex patients to try to figure out the actual costs of these things. I just think you're conceptually on the wrong track. There's about 40 or 50 years of health services literature about how you actually measure and price out physician contribution, nursing contribution, and so on. The idea that you're taking sort of a very primitive, broad brush approach that you're going to now figure out your own way of ascertaining this strikes me as not a very useful idea. I don't know this data set. It sounds like it could be an interesting data set in which to play to try to understand how you measure these things and compare these things. I'm not sure you're going to learn anything in this data set that actually is generalizable or that people will accept as being generalizable to anything outside the military system, but you may learn an analytic approach that would be useful that you could then take into other data sets. Every hospital has this sort of data. It's not unique to the DoD. What's unique is actually getting access to a database that has multi-hospital, actual data on resources used. And so if you have access to this one, I think it's a nice one for you to play in. I think you should, consider, writing a resident grant to get a little bit of support to pursue this, because this is at least as good as the ideas that I've read in other resident research grant. And maybe you'll start to learn to do this work, which I think is really important. But you come to this as though you have new insights into, this whole issue of, cost and price. It didn't just start, you're discovering it. And so I really encourage you to read more of the older literature where people did this ad nauseum, some better than others.
Yeah, so my understanding. Sorry, go ahead.
I'm going to move it. You have great responses, and I'm going to ask the two of you to talk after. But for the sake of time, I'm going to have us kind of go.
Yeah, let me just say, if you go to HRQ, you think you're going to get a whole panel of people that are expert. I'm the one out of the group that didn't understand it. I think you were talking about marginal cost. You started talking about it.
Yeah.
Seemed like that's what it was.
Yeah, but what I'm measuring here is not in the end going to be marginal cost. It'll be average variable. What I'm measuring here is not marginal cost. It's like average variable cost, which is something close.
And I didn't understand it.
That's
so,
okay.
You got to write to the newspaper.
Yeah.
Just out of curiosity, you familiar with this paper from '96 in the New England Journal by Robert Williams on the costs of emergency care? He was a ACEP president and kind of got famous for doing this marginal cost thing.
Yeah. So the estimates in the literature, I think this is maybe a little bit of what you're referring to, range from so Leisure and Zink reviewed this a few years ago, and there are a bunch of papers. There's Bomazai, there's that paper, there are a few others. And the estimates range from basically $150 to $1,500 or so for the cost of an uncomplicated emergency department visit, trying to sort of ballpark all the different, making the studies more comparable. And so there's just a variety of methodologies that produce a variety of different numbers, which is why I think the sort of relative differences are a lot more interesting than the overall number.
So I'm going to ask if there are offers that we can move on and give adequate time to our last three presenters.
Sure.
But Craig, did you have a comment or
I just have a quick comment. Yeah, so first of all, I'll echo a couple things that have been said. We need more health economists in the field. So Hats off to you for doing this work. I hope that you pursue an academic career kind of on a bigger picture level. I think translating or figuring out a way to translate this work into a career development grant, into future grants is really, really important. Yeah. And the NIH, costs and cost effectiveness are tricky words there. That are not fully supported. So you need to figure out a way to translate these ideas into fundable grants. And so one concept that I didn't see or hear in your presentation was framing this through a value framework. What are the benefits versus harms to patients by looking at these cost differences? Because it's not really just costs, right? And it also would back out to the question of whether a given patient needs to be in the emergency department, whether they could be, shuttled to a different form of care that may be less expensive, but that is not without risk as well. And really, I think the cost picture of the ED is also an issue of, kind of a bigger cost question. Are those key decisions of whether someone's going to be admitted or not? So I think putting this in the bigger picture of the healthcare system and a value framework may get you more traction for a career development pathway and future funding. So you probably know that better than any of us. I would sort of suggest that at least consideration of that in the big picture for what your path is. I don't know if anyone, I'm glad to help in some regard. Yeah. You are going to know far more than me as far as the cost piece, but I do have a couple grants that are NIH and AHRQ grants that focus on this value framework that basically integrate costs and how to get traction with federal funding agencies, integrating cost into the picture, these bigger health policy questions.
Any competing offers from Craig to Ari?
This is good. I think there will be some value in there. The right question. I mean, there's plenty of New England Journal and JAMA papers on veterans data, and it's not working in a trauma center, and it's all changes practice. I think DoD data is harder to look at, but it's valuable. But I want to make sure you do it right because I don't want the wrong data being published out there. Absolutely. So I'm happy to help on that side, understanding what that data set is about, where it's coming from, what the limitations are, because unless you're using, have been a provider, it's hard to understand that. Yeah. So I'm happy to help on that side and give you guidance there.
Great, thank you. I think, Craig, we've never met, but I'm sure I'm going to write you soon because we're on the same line. But I think like most useful for this project in particular would be kind of understanding the military data and the military world and things like that. And so I'll take that off.
Thank you very much.
Thank you all.
Another wonderful match.